This is the treatment plan for a full lower mandibular implant case, and taking a look at the CT scan and DICOM data here, notice the amount of scatter that the patient has from some crowns or bridges that they have in their mouth that are with a metal base. And if we were to just go ahead and crop the mandible, so we can just select the area of interest right here and eliminate the rest of the scatter that is in this DICOM, we would get a closer picture of what's going on. We'll go ahead and crop it and then convert the data here so we can get the MHA files and proceed with the treatment plan. Here, after cropping it, as you could see, we could see clearly where the mental nerve is on both sides. And one particular thing about this case is the very thin ridge of that anterior symphysis area of the bone, and that's going to be a little bit of a challenge. And if I put the the sagittal view right here and I start scrolling it back and forth, as I get to the front area right there, you will notice that scrolling it around the front symphysis there is going to show that the bone is extremely thin in that area, and it's going to be a bit of a challenge to place those implants in the front. So here it is as I come to the front, and notice it's very thin with a very nice base. It's almost like a golf club there, and that in and of itself presents a challenge for placement of the implants from canine to canine, from 22 all the way to 27. I will proceed with converting the data, converting the impressions, merging the data, and then doing the treatment plan. In this segment of the treatment plan, I'll go ahead and convert the impressions into an STL file and then generate a positive from the negative. And the learning pearl from this is always the impressions are the most important part of the fitting of the surgical guide in the patient's mouth. So I'm going to go through some details. Hopefully we can avoid some of these issues in the future. So looking at this case very quickly and looking at the maxillary impression, I'm going to zoom in on the maxillary impression. Notice a maxillary impression is the base for generating the guide. So the first thing that we would look at from this impression is that maxillary impression should have a palatal coverage when you put the tray material. The second pearl from this is the maxillary impression, or a mandibular impression for that matter. You should use a putty, a mixable putty, A and B material. I recommend usually the GC material, and then you would inject the wash on the teeth, and then you would take the impression. Never use the injectable tray material in the tray and then have your assistant take these impressions that way, because you can never get enough details. And if you have a tooth-borne or a distal extension case like on this side right here, this is a distal extension case on that upper left side, you will never be able to capture enough detail in there. And as the assistant seats this injectable tray material, it's more than likely that she's going to put enough pressure and she's going to touch the tray, and as a result it will be very difficult to segment the teeth from the tray. So always use putty, wash on the teeth, seat the putty until you capture all the details. Otherwise, these impressions will give you trouble seating the surgical guide in place. Once again, here we were able to generate the positive from the negative of the impression. Notice there's not enough detail on the palate, and the injectable tray material did not capture enough detail on the teeth, and then the distal extension here is not captured. So if you're planning to extract the teeth and place 4, 6, 8 implants, whatever, you need that guide to have some kind of a reference on the maxilla, and the reference will be your palate. And if you don't capture enough details on the palate and the distal extension, then you will have issues with seating that guide in place. So anyway, we made this case work, and we will proceed with it for now. But notice again, the distal extension on the left side is not there. I'll also show you the mandibular borders that were captured from the mandibular impression as well. And in this case, once again, no distal extension detail here, and you should inform your assistants to put maybe some rope wax on the edges of the tray so they can capture a little bit more of the buccal lingual vestibule area, especially on a distal extension area like this on the mandible, so that when you seat the guide you will have the guide seated on the teeth and the tissue so that you will place your implants perfectly. So treatment planning the case, we went ahead and generated the volume view, the bone view, the tissue and everything. We merged the data and traced the nerves on both. Here's the bone merged to it and the tracing of the nerves on both sides. We went ahead and also traced the tissue and segmented the tissue as well. And you could see that we also segmented the teeth as well. And if we remove the tissue and the teeth, you're looking at the STL data of the patient in a volume view. And at the same time, we traced the nerves and we know exactly what we're going to be doing now. So starting with the treatment plan, we will start by treatment planning the placement of the implants based on all this information that we have. By evaluating the volume view and look at roughly where the bone level is. So this is the left side. The bone level looks like it's around here where the necks of the roots are. And if we look on the right side, there's a huge dimple here which shows some bone loss in there. I'll adjust the hue in order to look at that a little closer and see if we can get a better visual on the bone view. And you could see that the bone is all the way higher, much higher than the bone on the lower right side. And if we look at the anterior, what would think that we have quite a bit of bone in there, but as we start evaluating closer and rotating the jaw, we could see that that ridge is actually very thin, and then the symphysis of the mandible is the area that is very thick. So the plan was to start treatment planning the implants on the left side first, so we can see what we can do with the right side as well. So I'll start by putting the implants in, and we will go ahead and click on the first implant on the back because we're trying to give the patient the first molar occlusion. And when we reverse engineered it, we went ahead and added a tooth there on the right side so we can give the patient the first molar occlusion on both sides. So starting with the implant on tooth number 19, I'll double click on it and I will bring in the active view, and we could see right here that we can actually place a nice 4.3 by 11.5. We're still away from the nerve area right there, and it should be plenty. We could easily put a 5.0 in there. We have the width, and the implant was placed right in the middle of the two roots, and it's right in the main vertical load of that tooth in the back that we will need. So tooth number 19 will be 4.3 by 11.5. We're going to go and place another implant. Again, if I put the bone view one more time, the mental nerve is right in the front there. We're away from the mental nerve. So we're going to try to place an implant on tooth number 20 next. And tooth number 20 will be again a 4.3 by 11.5 as well. It's well within the safety zone that we have. Notice the little curvature that we have right here. This is the safety zone around it. So by putting at 11.5, we're still way far from the nerve in there. And as we get to tooth number 21, we're going to be smack right on top of the mental nerve right here. And it's probably not recommended. The ideal situation would be to place an implant on tooth number 22 and place a nice long one anterior to the mental nerve, but the challenge here becomes the thin ridge of the mandible, the golf club shape of the mandible. And here of course we're going to have to go with a thinner implant. It's going to be a 3.5, or if you're using Strawman it could be 3.3 or whatever. And I would use a longer implant just to try to anchor it all the way down to the dense cortical plate of that mandible. So this should conclude the 3 implants that we plan to put on the left side of the patient. And as we proceed to do the implants on the right side of the patient now, a challenge that we have here is to put 3 implants, and one of them we want to spread the AP on the load vector, so we want to place an implant in between 24, 25, 26 area. This one is going to be right around 25 area, and the challenge now is becoming more and more evident that there is not much bone width. One would think that if we just reduce the crest of the ridge and put the implants lower, such as this, taking the implants, just flip it and bring the implant all the way down and put it in dense cortical plate. But then again, if you look at the crown to root ratio, it will be very unfavorable, and the left side the implants would be way too high, and on the right side the implants would be way too low. So it would be ideal to anchor the implant in such a way so that you can engage the at least 50% of the implant in dense cortical bone and graft the buccal plate a little bit more to support the threads of these implants. And that's the route we're going to choose. And here we're going to put a 3.5 or a 3.3 by 15, again long implants to anchor the bottom part of the implant. And as we go to tooth number 22, it'll be the same thing. We would like to put again a 3.5 by 15 long implant. It'll be anchored in such a way so that we can graft the buccal plate again. There's not enough bone in there. And then as we go to tooth number 30, here there's a little bit of bone loss in the back, and here again we'd like to use a 4.3 or a 4.1 by 10 millimeters, and we'll still be away from the nerve. We have nice bone width, but again I would not count on that as much. So the best way to do it is to fabricate two surgical guides, one for the posteriors, and you'll have a tissue bone guide, and you place the implants on tooth number 19, 20, and number 30. Then you extract the front teeth, and then you put the guide in, and you anchor the guide to the implants on tooth number 19, 20, and 30 with a template abutment, something that the Nobel surgical kit has maybe. And then you would use the second guide to place the bone anchored guide to the implants and place the anterior implants, which are 3.5 or. So just as a review of the surgical guide, this is the first surgical guide that we will use to place the three implants on the posteriors, number 19, 20, and number 30. Again, it's a tooth and tissue borne guide. So these are the teeth, and then the guide will practically sit on the teeth in the front, and the posterior areas will be able to place the implants in the back. Once we place those three implants, we would take the second guide, anchor it to these three implants, and then place the three front ones in the front. So the final spread of the implants: 19, 4.3 by 11.5 or 4.1 by 11.5, 20, 4.3 by 11.5, 22, 3.5 by 15, so the anteriors 3.5 by 15 or 3.3 by 15 or 16, and on the posterior number 30, again 4.3 or 4.1 by 10 millimeters.